Our next speaker will be Dr. Steve Han. Dr. Han is a professor of medicine and surgery, and he is going to update us about hepatitis B treatment.
Thank you. I'd like to thank the organizers for inviting me to come speak today. For the next 20 or so minutes, I'll take you through the hepatitis B story, which we haven't been able to find a cure yet for, but I think maybe in another 2-3 years, I'll be standing up here telling you that we can cure hepatitis B. So hepatitis B is a big problem, and there are more hepatitis B patients in the world than hepatitis C, probably 2 times as many hepatitis B. But the issue with hepatitis B is it's predominantly an Asian problem. 3/4 of the patients with hepatitis B are Asian. And it causes a lot of morbidity, mortality, a lot of cirrhosis, and it's the leading cause of liver cancer worldwide. So if you look at the world map, you can see that the high prevalence countries are Asia and areas in Africa. So the North America, the United States, is still considered a low prevalence area, but if you live in an area like we do, Los Angeles, where there's a high prevalence of Asian American patients, you will see a high prevalence of hepatitis B, similar almost to the same prevalence that you see in Asia. So how many, what is the percentage of hepatitis B in Asian Americans in the Los Angeles area? It's anywhere in the 10 to 15%. So 10 to 15% of Asian Americans here are chronic hepatitis B carriers. So the question people always ask is, why Asians? How did this stigma get brought upon Asians? And it goes back to how the hepatitis was acquired. In the Western countries like America and Europe, hepatitis B is acquired parenterally, so injection drug use, sexual transmission. The big difference is in Asia, hepatitis B is acquired perinatally. It's passed on vertically from mother to baby. So the big difference is that Asians acquire hepatitis B at a young age, as opposed to patients in the Western countries who get hepatitis B at an older age. So the younger you are when you get hepatitis B, the more immature your immune system, and it's unable to fight off the virus. So if a baby gets hepatitis B, probably greater than 90% of them will become chronic carriers. Whereas if an adult gets hepatitis B, they have a strong immune system, they fight the virus, and probably less than 5% become chronic carriers. And so that's how hepatitis B has been perpetuated in the Asian population. It's passed on from mother to baby. So we know that the at-risk groups are the kids. And that's why routine vaccination of all babies is now standard of care. And the OBs will screen all pregnant mothers, and if the mother is hepatitis B positive, not only does the baby get vaccine, the baby will also get HBeAg. And so we've seen with that routine vaccination now, we've seen a huge drop-off in new cases of hepatitis B. So a little bit about the virology. Hepatitis B is a DNA virus. It's small, but it replicates very efficiently, and it replicates at a very high level. The problem with hepatitis B is it replicates very efficiently, but it is error-prone. So hepatitis B is plagued with mutants, and one of the important naturally occurring mutants that we see is the so-called e-antigen negative pre-core mutant. And I'll talk a little bit more about that. The implications have to do with treatment. What we do know about the e-antigen negative mutant is that it tends to occur in older patients, and it tends to be more aggressive. So patients who have the e-antigen negative mutant tend to have more fibrotic disease. So here it is, you get a viral infection as a baby, 30 to 50 years of infection, can potentially lead to cirrhosis and liver cancer in some patients. And in hepatology, we've tried to understand this progression. We know hepatitis B is a very fluid infection, it's very dynamic, it's not stagnant. A patient can go through various phases of disease in a lifetime, and it can go back and forth from immune tolerant to chronic active to inactive, back to chronic active, back to immune tolerant. So the virus goes back and forth and back and forth. One of the things about hepatitis B, which is unlike any other liver disease, is hepatitis B goes back and forth between these different phases of infection, but patients with hepatitis B can get liver cancer even without baseline cirrhosis. And that's one of the big differences between hepatitis B and other liver diseases. You need cirrhosis for hepatitis C. You need cirrhosis for alcoholic liver disease before you can develop liver cancer. But hepatitis B, you can get liver cancer without cirrhosis, and so that's why we need to screen hepatitis B patients even in the absence of cirrhosis. So here's this virus, 30 to 50 years of infection. It can cause cirrhosis, it can cause liver cancer, and we've always tried to understand what tests can we look at to predict who is going to progress, because not all patients with hepatitis B are doomed to have cancer or cirrhosis. So what can we look at as physicians to give us an idea of who is at risk? In 2006, probably one of the most important studies in hepatitis B came out, called the REVEAL study, a large natural history study that was done in Taiwan with over 3,600 patients who they followed for 15 years. Chronic hepatitis B followed no treatment. So after 15 years of hepatitis B, they knew who got cancer, they knew who got cirrhosis, and then they could go back and look at predictive factors. They looked at age, they looked at gender, they looked at alcohol use. All the factors they looked at fell out. Nothing was predictive except for one thing, and that was the baseline viral load. And what they found is that a viral load at baseline of greater than 10 to the 4th copies per ml, which translates to 2,000 international units per ml, anything, a baseline viral load greater than that, if left untreated, had significantly higher risk of cancer in this case, and if the viral load were less than 10 to the 4th, the risk for cancer was significantly decreased. When they looked at cirrhosis, same thing, almost the exact same picture. Greater than 10 to the 4th copies per ml, higher the risk of cirrhosis. Less than 10 to the 4th, less risk of cirrhosis. So this told us that the viral load for hepatitis B was very important. So now we know that if you have a patient with hepatitis B who you're following in clinic, you need to follow the viral load. So now let's move on to treatment. This is where we have made great advances, but there are still a lot of work for us to do. Our treatments are very good at suppressing virus, bringing the viral load down, but we are not able to cure patients of hepatitis B yet or get rid of the virus. So right now we have 7 FDA-approved drugs for hepatitis B. The 5 drugs on top are oral drugs, and then there are the interferons, which are the injectable drugs. We don't very much use interferon in hepatitis C or hepatitis B anymore. So what is the goal of antiviral therapy in hepatitis B? Well, because we know that the REVEAL study showed us the importance of the viral load, the aim of antiviral therapy is to suppress the viral load, get the viral level down. And in so doing, we decrease the risk of cirrhosis or liver cancer. Now, the indications, who are the patients that we need to start on antiviral therapy? When you make that decision, you have to first divide your patient into one of 3 groups to start. You have to decide if your patient is e-antigen positive, e-antigen negative pre-core mutant patient, or whether or not they have cirrhosis. And in this day and age, our indications depend on 2 lab tests still. the viral load and the liver enzyme, the ALT level. So we still look at those two biochemical and virologic tests to determine who needs antiviral therapy. The different societies have all put together their recommendations, but you can see that the recommendations are fairly similar in that you need to know if you have e antigen positive, e antigen negative, and then again, the viral load and the ALT are the two lab tests you use to determine who needs treatment. So to help you understand this a little bit better, I have this little schematic here. If your patient is e antigen positive, the first thing you check is the viral load. If the viral load is low, now I put 20,000 international units here, but this recommendation is probably going to change. It's now probably going to be 2,000 international units, and 2,000 is going to be the marker that we use from now on. But if the viral load is low, then I give that patient a red light. And if the ALT is normal, I give that patient another red light. So I always like to tell our fellows, if a patient has 2 red lights, that's a patient that you don't need to treat. That's a patient that can be monitored over time. And I see my patients in clinic every 6 months. Now, if a patient has an elevated viral load, and again, we're going to start using the 2,000 international units from now on. So if the viral load is greater than 2,000 international units per ml, I give that patient a green light. And if the ALT is elevated 2 times upper limits of normal or higher, I give that patient another green light. 2 green lights, and that is a patient you should consider treating. Now, there are a lot of patients that we see who have a high viral load, so they get a green light, but their ALT is still normal, and that's a red light. So I call those our yellow light patients. Yellow light patients are what we typically call the immune tolerant patients. These are the young Asian patients that we've seen, with very high viral loads, sometimes 100 million, but their ALTs are stone cold normal, 15. And those groups were always very controversial. The societies always used to say, do a liver biopsy. If the biopsy shows fibrosis or activity, treat. If the biopsy is bland, you don't need to treat. But practically, we all know when you try to convince a 20 or a 30-year-old that they need a liver biopsy, they'll probably walk out of the office. So we needed a better way a better tiebreaker than a liver biopsy. Our colleague, Dr. Tong, came up with what we call a risk factor score. So you can use this risk factor score to assign points based on very easily obtainable characteristics about the patient. Are they older than 40? 1 point. Are they male? 1 point. Do they have the pre-core BCP mutation? 2 points. Do they have low platelets, low albumin? 3 points, 3 points. So you add up these risk factors, you add up the points. If the patient has 3 points or more, that's a patient that you should treat. So that's a yellow light patient that you should treat. If the score is less than 3, that's probably a patient you can continue to watch. The e antigen negative is now similar. 2,000 if the viral load is high, if the viral load is low, I give them a red light. If the ALT is normal, I give them another red light. So again, 2 red lights, this is a patient you can just monitor. But if the viral load is elevated, that's a green light. And if the ALT is elevated 2 times upper limits of normal, that's another green light. 2 green lights, this is a patient we should consider treating. What about if they have a high viral load, which is a green light, but they have a low or normal ALT, red light? So that again is your yellow light immunotolerant patient. In this case, apply Dr. Tong's risk factor score, add up the points, and if they have 3 points or more, that's a patient you should probably treat. If they have less than 3 points, that's a patient you can probably watch. If your patient has cirrhosis, the bar is much lower. All they need to treat is either an elevated ALT, you should treat them. If their ALT is normal, but their viral load is above 2,000 international units per ml, treat. So cirrhosis, the threshold is lower. Elevated ALT or elevated viral load needs treatment. If both viral load and ALT are normal, that's a patient you can just watch. So you've decided you want to treat your patient. So you have an e-antigen positive patient, they have 2 green lights, you decide I'm going to treat, you put them on antiviral therapy, and as you follow them in clinic, the first thing that drops is their viral load comes down, then their ALT comes down. So now you've made a 2 green light patient a 2 red light patient, which is great. For e-antigen positive, the recommendation was always treat until their e-antigen becomes negative, and hopefully they develop e-antibody. That's called e-antigen seroconversion. Once that happens, we say treat the patient for an additional 6 to 12 months of consolidation therapy, and then you can stop. You can take them off medication, and if you do that, what we have found is that up to 90% of the patients had this durable response. Their viral load stayed down, their ALT stayed normal, and you turned active hepatitis B into inactive hepatitis B. And this is just an example of the different medications. You can see that the newer oral medications to the right are much more potent. They're able to get the viral load down faster. E-antigen seroconversion is fairly similar among the different drugs, but you can see that not everyone e-antigen seroconverts, so the amount of time that you need to keep a patient on medication before the e-antigen seroconverts is very variable. You know, it could take a year, it could take 5 years. So, you know, when a patient says, how long do I have to be on medication? You say, well, until you e-antigen seroconvert, but I can't exactly tell you how long that will take. But if you do that, you follow that little schema, then most patients, as you can see, have this good durable response. If your patient is e-antigen negative, 2 green lights, so you start them on therapy, the viral load drops, next the ALT normalizes, so now they've become inactive. The problem with e-antigen negative hepatitis is they need indefinite or long-term therapy because all the studies have shown when you stop medication, almost 100% relapse. So these patients, once you start medication, it's lifelong. If the patient happens to be lucky enough to lose surface antigen, which is very rare, but if they lose surface antigen, this could potentially be a cure of hepatitis B, and then you can stop. Now, I'm going to say that with the e-antigen positives, remember we were treating them until the e-antigen seroconverted, but we have since found out that 5 to 10 years after stopping therapy, even in those e-antigen positive patients who have seroconverted, a vast majority of them relapse back and have to go back on treatment. So the newer recommendations are probably going to be, regardless of whether they're e-antigen positive or e-antigen negative, patients with hepatitis B, once you start therapy, are probably going to require lifelong therapy or until they lose surface antigen. And surface antigen loss is probably going to become our new endpoint for therapy. It happens very infrequently with antiviral therapy, and so all the new research is looking at different meds, different ways to make a patient lose surface antigen, i.e. cure them of hepatitis B. And so that's where I'm hoping, like I said, when I'm up here maybe 3 to 5 years from now, telling you that we have new medications that can now let a patient lose surface antigen on therapy, then we would have found a cure for hepatitis B. So again, the drugs, the newer oral drugs are much more potent at dropping the DNA. Now, like Sammy had discussed previously, hepatitis B has a big resistance problem with these oral antiviral drugs. And you can see that there are certain drugs that have low resistance and certain drugs that have high resistance. And it's the low resistance drugs that are the newer drugs. So tenofovir and entecavir are the newer drugs. They have the lowest resistance, and so now they are called the first-line drugs. And all the societies recommend that if you decide to treat a patient with hepatitis B, you should start with one of the good low resistance drugs, so either entecavir or tenofovir. And very seldom now do we ever recommend starting patients on lamivudine or telbivudine or adefovir because resistance is so poor. And remember, if you're going to keep a patient on drug for lifelong, you want to have a low resistance drug. So this shows you the two drugs on top, entecavir and tenofovir, very low resistance. As a matter of fact, after 8 years, we have 0 resistance with tenofovir. Entecavir is still well below 2% resistance. So avoiding antiviral drug resistance is very important. And basically, the best way to do that is to start off with a low resistance drug. So very seldom do we ever start patients off with something like lamivudine anymore because it's very high resistance. So in conclusion, hepatitis B, very prevalent in the world. We now know from the REVEAL study that the viral load is very important. We should screen our patients, find hepatitis B, determine whether you have a 2 green light patient, a 2 red light patient, monitor them appropriately, or treat them. And then, as I mentioned, treatment now is indefinite therapy or until surface antigen loss. Thank you very much.